Normally, air is inhaled and exhaled through the nose or mouth. To speak, sound is created as air passes through the vocal cords. When a person receives a tracheostomy tube, a tube is inserted into the trachea. With the tracheostomy tube in place, air can enter and leave the respiratory tract via the tracheostomy tube. Very little air will travel up the airway and through the vocal cords. Using a tracheostomy tube will disrupt the normal airflow, which will make it difficult for a person with a tracheostomy tube to speak. One solution to help a person with a tracheostomy tube speak is a device called a speaking valve. Join me this week as I discuss speaking valves. A speaking valve is a one-way valve which is attached to a tracheostomy tube or is used in line with a ventilator and tracheostomy tube. The valve opens when a person breathes in through the tracheostomy tube. When the person breathes out, the valve closes. The closed valve prevents air from being exhaled through the tracheostomy tube. Instead, air is forced up the airway, through the vocal cords, and out the nose and mouth. This allows the person to speak. Speaking valves also help a person cough and clear his throat. Candidates for speaking valves should meet the following criteria. The patency of the upper airway should be checked. There should be sufficient space for exhalation next to the tracheostomy tube. The patient should be medically stable and have stable vital signs. The patient should be alert and responsive. Important, the patient should be closely monitored and should not be left alone when beginning to use a speaking valve. Patient exclusions or contraindications for using a speaking valve include unstable respiratory or cardiac status, high therapeutic positive end expiratory pressure, history of tracheal stenosis, obstructing lesions or anatomical abnormalities which may impact the upper airway patency. Before using a speaking valve, individuals with any of the contraindications listed should consult with an ear, nose, and throat doctor. Criteria for stopping the use of a speaking valve include a significant drop in the oxygen saturation of the patient, peaks in blood pressure with thresholds defined on an individual basis, and slow heart rate. The following considerations should be made before using a speaking valve. If the person has a cuffed tracheostomy tube, the cuff must be completely deflated before using a speaking valve. Never use a speaking valve with the cuff on the tracheostomy tube inflated. Remember, the speaking valve is a one-way valve. It allows air into the lungs via the tracheostomy tube during inhalation. During exhalation, the valve is closed. With an inflated cuff on a tracheostomy tube, the person will not be able to breathe out. This will lead to death. The patient must be able to exhale via the upper airway. It may be necessary to replace the tracheostomy tube to a tube with a smaller external diameter, to a tube with a cuff which tightens more effectively, or to a tube without an inner cannula. This will allow the patient to wear a tracheostomy tube with a smaller external diameter, but the internal diameter will stay the same. If the patient cannot exhale despite the smaller tracheostomy tube, he may need to consult an ear, nose, and throat doctor. If it gradually becomes more difficult for the patient to exhale while using a speaking valve despite wearing a smaller tracheostomy tube, the speaking valve should be removed and the patient should be reassessed by a medical provider. The speaking valve is generally used for the first time after a prescription has been written by a speech pathologist. On the first attempt, the speech pathologist should give the patient instructions on how to use the speaking valve. The purpose of the speaking valve should also be explained. The patient should be positioned as vertically as possible. For best results, it is helpful for the patient to sit upright when using a speaking valve. During the first attempt with using a speaking valve, the patient should be closely monitored. Additionally, a speech pathologist should evaluate the patient as he uses a speaking valve. After the first attempt, the speech pathologist should report back to the medical provider in order to evaluate the use of the speaking valve and make suggestions regarding the wear time and frequency of the speaking valve. In most cases, the speaking valve is initially used for only a few minutes. If the patient tolerates the speaking valve, the wear time can be increased. Once a speaking valve is in place, speech therapy can focus on increasing the valve wear time, improving voicing, and speech coordination. With children, use of a speaking valve may be a frustrating time due to the changes in airflow. Music can be a less stressful approach to therapy. A patient is usually monitored at least on pulse oximeter when first using a speaking valve. If a patient's oxygen saturation drops while wearing the speaking valve, this can be an indication there is an excess in secretions. Suctioning should be performed before checking oxygen saturation levels again. There are two basic types of speaking valves. There are biased closed and biased open valves. Biased closed speaking valves are designed to be in the closed position. The valve only opens when the person breathes in. This means there's no air leakage out the speaking valve during exhalation. Instead, all the exhaled air is directed around the tracheostomy tube, up through the vocal cords, and then out the nose and mouth. Since the speaking valve remains closed, this promotes the establishment of a more normal closed respiratory system. A closed respiratory system is needed to help facilitate the cough reflex and for swallowing, secretion management, and decannulation. Passy-Muir valves are designed in a biased closed position. Biased open speaking valves are designed to be in the open position. The valve only closes when the person breathes out. This means there is some air which leaks out the speaking valve during exhalation. The benefit of air leaking out of the speaking valve is that there is less resistance when a person breathes out. This makes exhaling easier. The drawback is that the cough reflex may not be as strong, and swallowing, secretion management, and decannulation may be more difficult. An open position design may benefit individuals who do not tolerate the biased closed speaking valve. Examples of the biased open speaking valve include Shikani speaking valves, Shiley phonate, Traco phone assist, and Montgomery speaking valve. The Passy-Muir valve and the Montgomery ventrach are the only two speaking valves approved by the U.S. Food and Drug Administration for use on individuals with mechanical ventilation. Both valves may be used in line with mechanical ventilators. All ventilator settings must be re-evaluated for appropriate adjustments before, during, and after the use of a speaking valve. Exhaled volumes are not returned to the ventilator since the exhaled air is redirected through the upper airway. Low volume alarms will likely be triggered since the exhaled volume is no longer delivered back through the tracheostomy tube and through the circuit. In a retrospective study, patients who used a tracheostomy tube reported that being unable to communicate evoked feelings of insecurity, fear, panic, and anxiety, which made it difficult to sleep and rest. The isolation due to communication difficulties was reported to be a greater problem than any airway-related issue and was ranked worse than pain, suctioning, and difficulty breathing. This frustration can be reduced by providing a means of communication. When I first got a tracheostomy tube, I was given a speaking valve before being released home from the hospital. I did not know how to use the device. I placed the speaking valve aside and learned how to speak without using a speaking valve. When I finally had a respiratory therapist who knew how to use a speaking valve in line with my ventilator, I was told I speak well without the device. There is no reason for me to use a speaking valve. I have tried using the speaking valve, but I find it interferes with the settings on my ventilator. This causes my machine to constantly beep. Since I can speak without a speaking valve, I've chosen to not use a speaking valve. Thank you so much for joining me. Please remember to like and subscribe down below. I hope you have a great day and a wonderful week. Bye-bye. Hello. When I shoot my YouTube videos, I rely heavily on the sunshine outside. My computer camera does not do very well in low lighting or even with just the overhead lights on. It needs sunshine. So I've been looking at the calendar all week because we've had a lot of overcast skies and a lot of rain. And today was supposed to be the only day of sunshine. It was sunshine this morning, and by the time I got everything set up, it started clouding over and it's getting darker and darker and darker, and it looks like it's going to rain and I'm going to lose my beautiful sunshine and lollipops. So I'm trying very hard to quickly shoot this video, and I'm not sure I'm going to get it done, but hopefully, because I don't want to reshoot it because that's such a bummer. So that's just life here with a ventilator on my YouTube channel. Bye!